So chapter 28 is head and spine injuries. Got a couple of friends with me to help us get through this part. Bring you over here. There's a lot in this chapter which goes directly in line with your trauma assessment. As we do this, think on that sheet, right? We're checking the head, we're checking the cervical spine, but why are we doing that? And so this chapter is really focused on the head and the spinal injuries involved with trauma. And as we make our way through, get the introduction of the nervous system, again, the complex parts responsible for controlling the body's functions. Again, did bring my buddy over here. When we move to the spinal column, some different things that we're actually able to see, fantastic models from the, it's like 3B scientific company out of Germany. I mean, these things are awesome. Gives you a good idea what this stuff might actually look like, how these nerves can actually innervate through that spinal column. So again, make sure you get an opportunity to just grab some of these and actually look at the fantastic detail and how the face, the bones are actually set up. So when we start looking at, then we'll start up with the brain, spinal cord, and just all these nerve fibers that go in. You got billions of nerve fibers throughout your entire body. So the nervous system itself is well protected by the skull, right? That's its goal. The spinal cord itself actually has the spinal canal that's working to protect that as well. But it certainly doesn't mean that based on the injuries that someone suffered that these things cannot become affected. Of course they can. Head trauma, spinal trauma, paralysis are certainly things that we deal with. The central nervous system versus the peripheral nervous system, we'll start breaking these things down a little bit further and what they're responsible for. It's an example of how a sensory nerve and your motor nerves work, right? I actually put that up just as a little reminder: pulse, motor, and sensory, right? So when we go through and do that trauma assessment or potentially need to put someone on that C-spine board, right? Don't you remember squeezing their fingers? Hey, can you feel this? Can you feel that? Well, what we're checking there are actually the motor nerves, right? Do they have that function? Look, my motor nerves work. And sensory nerves are actually, hey, can you feel this? And if they can't, that generally means there's some type of injury to that portion of the spinal column. So in the CNS or central nervous system, brain and the spinal cord. Again, as we get down into the brain, we'll actually break that up into these three different groups, and some good illustrations about where they are in the brain, how well protected they are, and in addition to that, seeing what each of these areas is responsible for. But the brain, think of it as the control center. It's controls that consciousness in there, but it's the big CPU, right? That's everything you need to maintain life. So as we look at the three different areas, it's broken up into the cerebrum, cerebellum, and the brainstem. Look at the areas about where these things actually are, right? Cerebrum, okay, that outermost portion of the brain, but the brainstem, most well-protected part, and then of course the cerebellum. So looking at what these things are responsible for, the cerebrum, lots of activities, your voluntary motor functions in there, conscious thought, move down to the cerebellum, balance and body movements, right? And so if someone's not, able to move this side or that side, or potentially a stroke could affect these things as well. Again, that's how these different areas of the brain can actually be affected. You move down to the brain, that's most functions required for life, right? Breathing, we get into specific parts of the cervical spine in different areas that can actually be damaged. I mean, this is, probably this is the most exciting chapter, lecture, trauma module you're ever going to have, because this stuff is purely amazing. On the spinal cord, and again, we can give you the spinal cord, and that's why I say make sure you look at these things and get the idea about how these things innervate or move through each other. but that carries messages between the brain and the body via this gray and white matter, right? It can send some signals, and there's some really cool times where it can just bypass that and send it straight to the nerve. Example is if I touch something hot, it immediately pull away from that, but then it actually bypasses the brain and sends it directly to the nerve itself. The protective coverings, again, there's this thick, bony structures in the brain and the spinal cord. That's what they're actually covered with. And just as a tease, that's why when we start looking at intracranial pressure, or anytime that brain can start to experience some swelling, why that's so bad, right? The inside of the skull itself is not this perfectly, round, smooth surface. There's bony prominent parts that can actually, as that brain starts to expand because of the pressure, can actually tear that up. So again, ICP isn't really something you need to know. Intracranial pressure runs from 5 to 15 millimeters of mercury, but we do have to be aware of some of the signs and symptoms that intracranial pressure could be increasing. Again, one of the ways to think about that is anytime there's potential injury to the head, and we'll look at different fractures as we make our way through here of the skull itself, that gives you a high index of suspicion that they could be experiencing that increase in the intracranial pressure. But the CNS, further protected by the meninges, again, meningitis, inflammation of the meninges, again, not really my concern at this point, but just that's an example how we start learning these terms and where and what that actually does. That's why that could be a concern to us. The outer layer, the dura mater, that's the toughest part there. It forms a sac that actually contains the CNS itself. And it gives, when we look at different bleeds and where this could be happening, there's certain signs and symptoms we may see that can show us it's related to that area. Not, I don't call it super important, but again, any brain injury, any traumatic brain injury is something that we have concerns with because it could ultimately affect that person's life. The inner two layers, the arachnoid matter, and then the pia matter. There's a good description here as we look down and where those actually are in the brain. Those contain most of the blood vessels in that area. So keep this in mind when we start defining, arachnoid or subarachnoid bleeds. Again, that's below that area, but this just kind of gives you that nice setup. We can see how much protection we have here between the skin and the skull itself. As we start moving down inside that area of the skull, that's where you see the dura mater, arachnoid, cerebral spinal fluid. We always mention CSF, right? I'm looking in the ears, the nose for CSF. And again, there's certain fracture types which would be leading you to potentially see that bloody CSF, or CFS itself is of course bad. And we always are concerned that there's some type of, in particular, a basilar skull fracture with that. The cerebral spinal fluid, again, and why it's important, why are we worried if we start seeing that viscous kind of fluid that comes out? There is a test for CSF. It's called the halo test. You can put that on and see a lighter area surrounded by a darker area. Again, honestly, if I've got something coming out of the patient's ears or nose, and it's not just a booger, it kind of looks like that motor oil consistency, I'm going to think that's CSF. Probably not going to drop that corner of my gauze to do this halo test, but no, there is a way out there that you can test for it. It shouldn't be done if it's going to slow you down or get you moving. That just tells me that index of suspicion, hey, they're leaking CSF, is there, right? There's fluid that's coming out that should not be coming out. But being that shock absorber, it's really important that they don't lose that, because then is that brain more susceptible to this whole contra coup injury pattern that we have. Again, that comes up a little later on in the slides as well. But can't help myself. This is exciting stuff. This is some really interesting part of the trauma. Again, I think it does a good job to explain why. Why are we looking for CSF? Why is it so important to make sure we don't move that person's neck if there is a potential C-spine injury? So for the the spinal nerves themselves, the cervical, thoracic, lumbar, sacral, and coccyx, 7, 12, 5, 5, 4 are your spinal nerves. When you get into the cranial nerves, those are things that can control certain things like your tongue movement the parts of the face, you know, potential paralysis in there. And that's getting more to the medical side when we start worrying about the stroke or a stroke assessment. But you can certainly have some impairment based on the severity of some of these head injuries that we're going to see. So how these come down, again, 7, 12, 5, 5, 4. It is important to remember, such as the brachial plexus, this nerve bundle where you've got a bunch of these fibers that come together. You've also got the lumbar sacral plexus. Again, it's just an area where a large group of nerves actually come together. The peripheral nerves, and again, this is going back to that part of the assessment, sensory and motor nerves, right? Motor nerves carry that information from your central nervous system to the muscles, right? Tells you, hey, I can do this, I can move. Pulse motor sensory, why we have to check that. On the sensory nerves, carry only one type of the information from the body to the brain via the spinal cord. And sensory is the one that's pretty fascinating because it can, with some painful stimuli, whatever, just bypass that and send it directly to that nerve itself, or it'll just pull away directly. And again, these are all happening because of your billions of nerve fibers and taking place over, again, just a fraction of a second. The connecting nerves found only in the brain and the spinal cord. It's the only time you're going to see those connecting nerves. But what they do is they connect that sensory and the motor nerve with these small or short fibers. But it does allow for the exchange of simple messages from the body to the nervous system. The nervous system, again, looking how this stuff actually works, these reflex activities. Reflex, check reflexes, right? That's something that the CNS is going to provide. The voluntary activities, consciously perform this, right? I can do this, but that's a voluntary activity. There's also some, and when you look at the involuntary activity, such as breathing when you're sleeping, it's not under your conscious control, right? I don't have to think about breathing when I go to sleep. I certainly hope I don't have to, but that's an example of the voluntary, right? You decide to do that versus an involuntary activity. Connecting arch, nerves in the spinal cord that actually form this reflex arch. This is where if you actually have that annoying or irritating form of stimuli, it can bypass the brain and send it directly to the motor nerve. Right? Again, and all done so fast as this is taking place, but that's just a pretty unique idea or concept of what the body can actually do in really as a means to protect itself. The somatic versus autonomic part now of the nervous system, just somatic, think about voluntary activities. Okay? And what's unique in that is the diaphragm, voluntary or involuntary, or under control of the somatic or the autonomic nervous system, it's actually kind of unique because it's both. When you look at the autonomic or involuntary nervous system, autonomic makes me think of automatic, right? So I really don't have to think about doing something. It's involuntary, things such as the peristalsis or things moving through your digestive system. You don't control that. And that's an example of the autonomic nervous system. We also have the sympathetic and parasympathetic nervous systems. These are cool as well because when we get into certain weapons or different types of chemical agents that may be out there, they can actually mimic the effects of these nervous systems. But the sympathetic, that's what we refer to as the fight or flight. The parasympathetic nervous system has that opposite effect on the body. And when you think of some pathomimetic or a medication that may, cause that increase in blood pressure and pulse, parasympathetic is actually going to slow that stuff down, right? It does the opposite of what the sympathetic nervous system does. Skeletal system, the skull, right? Skull, it's pretty tough. All skulls are pretty tough. It is there to really protect that brain, right? You have facial bones in here as well that work to protect that area as well. The zygoma, when we move through to the mandible, and then the maxilla, mandible, zygoma, that the brain does connect to the spinal cord, but where it actually does that is through this big hole foramen magnum, and it's kind of hard to see in here. I don't really think I can get the right angle, but look at any example of the brain or the skulls that we have out there. You notice on the bottom part of that, there's a big hole. And foramen magnum, Latin, of course, everything's got this basis in Latin, but that's what that actually stands for. The bones that make up the cranium itself, the occiput, temples, the parietal region, and then again, the frontal region here. These are kind of nice because they've got those color coded for you. You can see that. But the face itself, the maxilla, the zygoma, the mandible, the nasal, and the frontal bones, there are 14 of those in there, right? The body itself has 206 bones, but now we're simply concerned with the bones of the skull itself, the facial bones. And why we want to know what's there is that as we think about that trauma assessment, we go through and we're palpating and we're inspecting. One of the things that I hope you got an opportunity to see was old Fred over here, right? Trauma head Fred, as you go through and you're assessing him, he may have a certain type of skull fracture that we see. I think it's actually the last one in the skull fracture section, but that's why we have to inspect, palpate, right? When we're down at the chest, we inspect, palpate, and auscultate. But here, you want to make sure that you're not missing any potential injury. And why that's so important is when we look at any type of these head injuries, could that lead to an increase in intracranial pressure? Or is there something I missed on that C-spine? Now maybe this bone is moved over one side or the other. How's your patient's breathing? Again, there's certain injury areas and patterns that we'll see that can certainly affect that, some more so than other, depending on the height in the spinal column or the cervical spine of where that actually is. So the spinal column itself, 33 vertebrae, 712, 554, cervical, thoracic, lumbar, sacral, and coccyx. Right? That's just where we're looking at with the spinal column. And what's unique is each one of these nerves can actually show up if they are damaged with different types of limitations for the patient. Right? Someone who has a L5, S1 lumbar sacral injury may have some numbness or tingling on their left leg. Right? Remember, when we go through and do our assessment, that's what we're actually assessing them for. I might not know if you can, can you feel this? Can you not? And yeah, it's a little decreased on this side. And again, that's all information that's going to be important to relay, because it could show this type of back injury versus some other type of back injury, say in the thoracic spine. But there are the vertebrae in there, and they've got that cushion, which is the intervertebral discs. And how this has always been described to me is if the jelly comes out of the donut, that's going to lose that ability to maintain that cushion. And why the cushioning is so important as we look at the disc itself here is, imagine taking that out. That can cause compression injuries to those nerves that sit above or below that area. Again, if you've ever heard the term herniated discs, what's happening is that there's pressure on there. It's herniated. It's building up that pressure. Now, if it actually ruptures or they lose that, I happen to have fake discs in my spine. They put these little cushions in there. So it's amazing a lot of the things that can actually be done now. But the spinal column itself, and this is why it's so important to have proper lifting and moving, it's surrounded by muscles, right? And if you do something and twist or lift something the wrong way, then it can aggravate that. And the more trauma that is put on the spine, and the more you continue to tear, potentially damage those muscles, that can have long-lasting effects. That's more for a you thing versus the patients, right? Right now, I'm just trying to make sure, hey, are you breathing? Do you have a pulse? But we always want to keep ourselves safe as well. So again, cervical, thoracic, lumbar, sacral, coccyx, just know that order. Guarantee you that comes up. It may be in ascending order, it may be in descending order, either one of those, but you just have to be familiar with the spinal column itself, and then how many there are in each of those areas. So for head injuries specifically, head injuries account, again, most of the traumatic deaths. Here we say more than half, right? That's most of them. Fatal injuries can involve the brain. Again, it could be a penetrating trauma. Just like in soft tissue injuries, there are open and closed injuries that we may have to deal with for the brain. But also, if there's enough energy or trauma that they've suffered to the head or the spine, what else did they suffer, right? Is there more trauma on the body that we haven't found? Which is why when we do that assessment, remember we're doing a head to toe assessment, the anterior as well as the posterior portion on your patient, because we can't miss these things. And if they're unconscious and unresponsive, then that's why we have to do that, right? That detailed physical assessment to make sure nothing has been missed. But closed versus open injuries, now, there is some type of trauma, usually a blunt force trauma that's happened, but there's not an actual opening to the brain. On the open injuries, typically something that's by the penetrating trauma, again, gunshot wounds, stab to the head, whatever it is, but there could be bleeding, there could be exposed tissue to that. Again, that's the difference between an open and a closed injury. One opens up the tissue, the other is just a closed injury. They're both bad, but doing our assessments, just be aware, just two very similar to the soft tissue injuries. Even in the chest chapter, because I got to say, I thought I was doing the chest injuries first, but I noticed Paul's already done that, so thank you. But there's open and closed chest injuries, right? We can have open and closed injuries to the head as well. The motor vehicle crashes, this is the most common mechanism of injury for that. And there are things, assaults, falls, helmet to helmet, sports related injuries. Those two are mechanisms of injury that we have to be aware of. Now, one of the sheets, when you start looking at the signs and symptoms of a head injury, that one's much easier to see off of table 28 for you. Again, it should make sense as you look through these that, yeah, that could certainly be indicative of a head injury. Scalp lacerations, again, they can be minor, they can be serious, but it can lead, right? It's very vascular when you're dealing with the scalp itself. The gentleman, think about shaving and just kind of cutting your face. How long does that bleed for when you cut yourself shaving? It seems like about 3 days. So same idea about the vascularity that's involved with the scalp. Again, children, they don't have as much blood. They're not going to tolerate that as well. So that's why it becomes a grave concern with different patient groups. What I didn't see was specifically dealing with geriatric patients, but we need to start building that critical thought. I've got an 86-year-old patient who, fell in the parking lot. They've got this little lack right here. Well, now let's throw in the combination, or certainly the questions. Are they on blood thinners? Do they take aspirin? Again, aspirin, not a true blood thinner, different. But again, knowing if they took that aspirin a day, that could increase their risk for bleeding. And also, is it something that could increase their risk for bleeding into the brain as well? So what may come across as something that looks relatively minor, our index of suspicion is that, hey, this might not be so good, right? All those patients we're going to cover with that quote protective blanket and make sure we get them checked out. And the skull fractures, maybe open or closed, right? Either one of those is certainly possible, but that's why I go back to trauma head, Fred over here. Just make sure you get a feel for that. I get the idea that a lot of these chapters assume that your patients are just bald and, look, I can actually visualize that linear fracture. Not the case, right? A lot of patients got a lot of hair. And so again, to, shine the light, whatever you're doing to look into that, that's one of the ways we can either rule this in or certainly rule that out. Do a good visualization of there, and be careful when you're palpating the skull, because I don't want to just do that. I want to use that gentle motion to find and feel, do I see anything different? So some of the signs of that, patient's head appears deformed, and I'll ask your patient if their head normally looks that way, but seeing some actual visible cracks in the skull. Ecchymosis, the term we introduced in the soft tissue injuries for that, just bruising under the eyes for this raccoon eyes, and there are some illustrations of battle signs as well, which are actually kind of cool. So maybe you can see why it's called raccoon eyes. The battle signs here, those are just indications, and I'm going to say skull fracture, right? Skull fracture, got to make sure we're transporting these patients safely and to the closest emergency department. Now, the specific type of fractures that you could see, one, of course, the linear skull fractures. When you look at the propensity for this, it's about 80%. 80% of skull fractures are these linear skull fractures. This is great as well because you still need the x-rays in order for that to truly be diagnosed, but they might not have other physical findings. So again, what are we basing that on? We're saying that's an index of suspicion, right? Based on the mechanism of injury on this patient, I need to be aware that this certainly has a potential to lead to that type of a skull fracture. The depressed skull fracture, high energy direct trauma to the head. One of the, really probably the last one of these I saw was a person who was ejected from a vehicle, not wearing a seatbelt, and the depressed skull fracture was actually in the outline of those little markers on the freeway. So the person had come out and bam, but that's a depressed skull fracture. The bony fragments may be driven into the brain, right? That's kind of a bad injury pattern. On the basilar skull fracture, high energy trauma, but look, signs include CSF, drainage from the ears, raccoon eyes, or battle signs. Again, so a basilar skull fracture doesn't mean that you can only have CSF with that type of fracture, but that's why we have to be so cautious. Look in those ears. What do you see? Again, as far as the treatment goes, we're still going to make sure that the patient's loaded up appropriately, right? They're going to make sure we protect that C-spine. But now in certain types of skull fractures, you're more likely to see CSF draining from the ears, right? The open skull fracture, again, with something like this, you're looking at multiple trauma, multi-systems trauma, trauma to the head, the chest, you know, all of those areas, because it's such a, you know, massive amount of trauma to actually break through to that skull. So what else did they suffer, right? How was that energy dispersed throughout that person? It's very unlikely that it was just focused in on that part of the skull itself. Traumatic brain injuries, or TBIs, there are two different categories related to this. There's that direct injury, and the direct happens from the immediate impact on the head. But where that secondary brain injury, this makes the first injury worse. And items such as the hypoxia, right? Not getting enough oxygen, hypotension, there's swelling or cerebral edema, pulmonary edema, right? All those things just mean an increase in the swelling or the buildup of that fluid. The intracranial hemorrhage, so something can actually be bleeding inside. So that's the secondary part of a TBI. And here's some other things on the coup contra coup. So again, initial impact on the front part of the brain, but then when the head falls back against the headrest, does that cause that shifting of the brain as well? And so anyone that is involved in that certain type of mechanism, this is our suspicion for them. The cerebral edema, swelling in the brain. Now, what's fascinating about this as well is that it may take several hours following that initial injury. So just things we're aware of, oh, I don't want to go to the hospital and someone, you know, whack their head pretty good, you know, to be on that safe side. This is why we would encourage said transport. Intracranial pressure, again, the brain is in an enclosed cavity, right? And if there's insult or injury to that, it can swell, just like we saw in the soft tissue. You have this buildup of swelling in there. But what's bad about that is that increase in the pressure can actually cause that brain itself to press up against some of the bony prominence of the skull. So it's definitely a concern. intracranial pressure, and there's monitoring that can be done with that, of course, in the hospital, and they keep an eye on the patient. But there's the worst form of that increasing intracranial pressure is something called a brain herniation, right? That's when it starts to press against that inside of the skull, but it can also be forced out that foramen magnum as well. There's so much pressure that's built up in there. The Cushing's, well, I always called it Cushing's triad. You can call it Cushing's reflex, but with an increase in that intracranial pressure, these are some of the things you tend to see with that. Specifically, you see the headache, the nausea, the vomiting, right? Decreased alertness, or starting to have drops in their level of consciousness, changes in their pupils, right? We did day one, we were looking at pupils, and we know these things should be pearl, but now, because of that increased pressure that's in the brain, you might see that actually slow down. Different posturing, and this is a good time because I don't think this is the be-all, end-all on the Glasgow Coma Scale, but it is an example of the cerebit posturing, which is an indication of a deep brain injury. And I know we'll go over GCS, or at least kind of review that right now. But then there's the specific signs of Cushing's reflex. And Cushing's reflex, Cushing's triad, see that increase in the blood pressure, the irregular breathing pattern defined as the Biot's or the Shane-Stokes. I know your book has like these respiratory patterns where it goes, and that's what you're looking at, those wave formations and how they may change. Then, of course, the bradycardia associated with that. Again, that just has to do with that change in the pressure in the brain and how it's affecting that. Intracranial hemorrhage, again, and I think this will also look at different types of brain bleeds that someone can have. But the bleeding can occur, here it is, between the skull and the dura mater, between the dura mater, but outside the brain, and actually inside the brain tissue itself. And those are the ones that we're coming up with now. And if you've ever heard epidural, okay, where is my epidural hematoma located? Well, accumulation of blood between the skull and the dura mater. Always, nearly always, as a direct blow to the head. The could be that linear fracture. And think about all these things that could be possible, because 80% of those skull fractures are actually that linear fracture. So it's just something that we're always on the lookout for, right? My index of suspicion is always great following any type of a head injury or motor vehicle trauma. The subdural hematoma, accumulation of the blood beneath the dura mater, so subdural, below this. The after falls, injuries, again, strong deceleration forces can lead to that. The intracerebral hematoma, and that's actually what's so cool about this. These are recorded. You go back, you could see these again, look in the book, just kind of see exactly. I know the illustrations or the pictures here might not be as clear as if your book's in front of you, but it's kind of a cool combination that we got going on. So I know these pictures appear in the book as well. But how do these happen, following a penetrating injury to the head? Or again, that rapid deceleration forces. Again, why that intracerebral? Because it's actually in the brain itself. Oh, penetration, something had to go in there, which actually caused that brain to start bleeding within itself. The subarachnoid hemorrhage, again, there's bleeding that occurs in the subarachnoid space. And why that's bad is that's where the CSF circulates. And so when we look at this bloody CSF, right, is it bloody CSF? Is it clear CSF? But again, passing that information along, that neurosurgeon is going to get that information from you. So again, they have a higher suspicion of this type of injury. Could be trauma, rupturing of an aneurysm. What kind of aneurysm? Could be a cerebral aneurysm. Yeah, that's why it's so important to relay this information as you get them in your finding, which is why on the trauma sheet, watch me misspoke. I don't know, that trauma sheet also had the verbal report, but that may only be in medical. But those are all things that would certainly be implied when you get to the hospital. You got to tell them everything you found, as well as doing that on the radio or via your telemetry. On a concussion, there's a lot of things out there with concussions now. The repeated concussions can actually change that structure of the brain. But when we look at this and the definition from that, temporary loss of alteration or part or all of the brain's ability to function without physical damage to the brain, right? So the brain itself is not permanently changed. Now, again, that is something that could, over the course of years and repeated concussions, is actually showing now that it can actually lead to that permanent damage. But we're talking right now, single concussion, bam. 90% of those patients also do not lose consciousness. So find someone like that, they're talking their normal right now. It's kind of how it goes with a concussion. So we look at the mechanism behind it, and index of suspicion is up here, as we can't really rule this in or out until we get them to the hospital, but you can certainly suspect that. They may be confused. It's usually this brief period of time for the amnesia or not remembering what has actually happened. But assume that patients with signs or symptoms of concussion have a more serious injury, or they could have that more serious injury until proven otherwise, right? That is just index of suspicion, and something we always have, especially with these head injuries. Now, unlike a concussion, a contusion is more serious. Okay, there's actual physical injury to the brain tissue. So could be long-lasting permanent damage. This definitely falls into the category of a TBI. Patient may have all those signs and symptoms, or they may be milder, again, depending on the time it takes that swelling to develop, which is why I'd much rather have them en route to the hospital if they start exhibiting those signs than sitting back at home because we just, did a refusal on that person. The other brain injuries, again, they can be medical conditions, clots or hemorrhage. What's another way to say that? Strokes. Hemorrhagic strokes versus ischemic stroke. Those are usually clots that prohibit the brain from getting all of its oxygen. And in a hemorrhagic stroke, there's some type of vessel which is burst, and now there's too much blood in that area. But they can look a lot like someone who suffered a traumatic brain injury. With the spinal injuries and compression injuries are that force that compresses the patient's vertebrae, and that can cause the jelly to squirt out of your donut, or the herniation of discs. Motor vehicle crashes can certainly cause those spinal injuries. We know so much about the cervical spine, and we're always on the lookout for those, but it could also be a lower portion of the back, could be in that thoracic region of the spine, right? Rotation and flexion. So, and I'm going to take it out. I hope this whole thing don't fall apart on me right now. But just think about someone who's experienced this great twisting force and what that has to do with the ability to affect those nerves in different areas of the spine. So it's not just the cervical spine we're worried about. We are worried about the cervical spine because of breathing and the opportunities for paralysis, but it can be other injuries in that spine as well, which are just as well. They're painful and they can be relatively debilitating. So when the spine is pulled along its axis, or this hyperextension, can have those fractures that leads to. Again, when we look at an unnatural motion, that can result in some type of break or neurological deficit. And the neurological deficits that we're assessing, again, pulse, motor, sensory. I know I jumped ahead on this stuff before, but you're palpating that person's leg, and they're like, oh, it's numb. Or, no, it doesn't feel like when you touch the right leg. Again, remember, this is a rough, that 10-minute assessment. You're out in the middle of the streets. Again, if we can document that as best as we can, see if there's any changes, kind of segueing us into trends and watching to see what's actually happening to the person while you're in the midst of that transport. But it does become very important to note, hey, this leg felt fine. I did my reassessment. Now they state that the left leg is numb and tingly. Okay, good information to have, and of course to relay. Now, mechanisms. When talking about mechanisms of injury, and there are times that you should always suspect a cervical spinal injury, or I should just say a head and spinal injury, right? Cervical, again, we're just so focused on cervical, but again, it could be any area to the spine that is actually affected in addition to the head. So motor vehicle crashes, right? What are some questions we're going to ask in regards to a motor vehicle crash? Did you have your seatbelt on? How fast were you going? Looking at potential intrusion of the vehicle to know that's the trauma that they suffered. Pedestrians, of course, pretty obvious injuries with that. Falls, how far did they fall from? What did they land on? You know, blunt trauma, if someone's just hit in the chest, does that mean that's the only area that could be affected? Well, certainly not. And then any type of those penetrating traumas they could suffer, because could it go through to the spinal column? Again, there's so many areas that trauma can, people can be affected. The continuing on, when we look at the hangings actually causes something known as a distraction injury. So again, it just pulls that along. The diving accidents, and when we talk about diving accidents, you find someone unconscious. Well, let's just say somebody pulled them out of the pool before you got there, because if they're unconscious and unresponsive at the bottom of a pool, chances are that person's drowned. But they dive into the water, that water's too shallow, and now they have this potential neck injury. So that's why diving accidents pop up on there as well. So getting into the primary assessment, right? Airway, breathing, circulation. Assess the patient in the position found. Again, there are sometimes we might need to roll them. And when that patient is prone versus supine, right? Prone means they're on their belly. Well, we're gonna have to roll them over because we need to assess the airway. But the backboard can help put them on that, depending on how far you need to assess. But this is cool. Backboard often places a patient in an anatomically incorrect position for a long period of time, which is why this thing called SMR is around, spinal motion restriction. If the person is not suffering numbness or tingling or have that clear indication of the spinal injury, then it's potentially better not to put them on that. But the scenario I'm going with now is, unconscious, unresponsive, patient, or not the patient, but the bystanders tell you directly what happened, which is why we may actually need them on that board. Again, that is different considerations for different agencies. No, it's always important that we make sure we protect that spine if you have any thought that it could actually be damaged. So on the Glasgow Coma Scale, and I'm sure these are things you'll have to have conversations in class just to clarify, but the Glasgow Coma Scale, Glasgow was a neurologist, and he came up with this scale that shows how deep someone's neurological injury can actually be. And when you look at the 1, the 1, and the 1, okay, none, 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 means they're not opening their eyes, they're not responding to you, and they don't have, those motor responses. Okay, everything gets a 3. This guy right here is a 3. I happen to be a 15. And so somewhere between 3 and 15 is where all patients are going to lie. The eye opening, the verbal, and the motor response. Eye, verbal, and motor. It's just kind of a way to remember the things that we're assessing in a GCS. If you think eye, verbal, motor, 4, 5, 6, that's just how you can remember what points are associated with this. It doesn't get into the different types of posturing, but remember one thing we saw in there was it said decorticate posturing. And decorticate means you're coming through the core. And when I do this, it's more of a flexing motion. So decorticate posturing is abnormal flexion. Abnormal extension, the cerebit posturing, taking it away from the body. Well, which one of those is actually worse? Well, for this one, they get a 3, and then for this one, they get a 2. Remember, the lower that scale, the more severe that neurological injury is. So that's why the GCS scale was, utilized. I know on the trauma sheet, it says transport based on calculated GCS, and that's awesome. But you've got someone who's unconscious, unresponsive, this potential head injury, right? If I need to make sure we are transporting that patient. And again, as far as getting these things, you can, but what really tells me I need to transport is the severity of my patient's injury, and I'll get that GCS as soon as I can. But I just want to look at that patient first, and you can tell potentially in your general impression, is this person good or are they not good? Which one is it? The care. So what are we going to do for someone that actually has a head injury? Okay, open the airway. What's the first thing you do in that primary assessment? We're going to assess the person's airway, right? If it's good, might drop the OPA, bag them. I need a lot of other information: respiratory rate, rhythm, and quality. How is that tidal volume? But general principles. We got to make sure we're taking care of the airway. And what goes with airway? Airway and breathing. The bleeding, if there is something that is going to lead to, again, that lack of blood, it's an arterial bleed. You want to make sure you're controlling those major bleeds first. But if it's a little bit of road rash on the arm, then that's not something that falls into that critical criteria. Monitor the patient's level of consciousness, right? They can wane in and out of that depending on the severity of the injury. They may be up fine talking to you right now, and then I feel like I need to go to sleep, and they just go out on you. So again, that's why it's so important to make sure we keep monitoring that, because it could tell us about that intracranial pressure. Once the airway's open, how would we open the airway of this suspected spinal victim? They're unconscious and unresponsive. That's where the jaw thrust comes in. The neutral inline position until you have determined the appropriate spinal precautions, right? That's SMR, spinal motion restrictions. If there are any foreign bodies, what do we do in the airway station? Oh, look, you look in the mouth and it's full of secretions and vomitus. So making sure that airway is clear, giving the supplemental oxygen. Again, it could be a non-rebreather based on their tidal volume and their rate. Could be someone that you're actually bagging, again, depending on those factors. Just an example of maintaining inline neutral mobilization of the spine, right? That's what they're doing. Why are they doing it? Because this guy was found potentially on the ground, and unless he laid down and just went like that, or did he just fall, right? And when you go unconscious, your arms aren't there to protect you, so there is going to be some jarring of the neck, which is why you want to make sure it's protected. Circulation, well, if the patient's in cardiac arrest, we should do CPR. But the circulation also, as we assess that, could be some minor bleeding that we find. If I see the scalp lac, and scalp lacs, because of their vascularity, we want to put some direct pressure. It's not, right, everything I can as I push that down. On the head or the scalp injuries, we tend to use a lot more gauze because I don't want to put a lot of pressure on that. But with the shock, a result of the hypovolemia, again, that's how shock is usually a result of that hypovolemia in these types of cases. So the only way that's truly going to be addressed, or I should say fixed with definitive care, is getting the person over to the emergency department. Cushing's triad, this came up again. That's why I wanted to show you it on board. But again, we already saw what these were, right? The increase in the blood pressure, the decrease in the heart rate, and then the Biot's or the Shane-Stokes respirations. So right down here, perform controlled hyperventilation of your patient via positive pressure ventilations, means bag valve mask, right? Positive pressure at a rate of about 20 breaths a minute, right? Your typical breathing for trauma is 10 to 12 breaths a minute, right? It tells you not to exceed 12 breaths per minute. Then we got this, not advised if the advanced monitoring is not available, example, end-tidal CO2. So again, if you don't have the end-tidal CO2, stick with your 10 to 12 breaths a minute. This is in an advanced setting, get into a little different type of trauma assessment, but it wouldn't be expected that you would be doing a controlled hyperventilation on the patient, just because you likely that you wouldn't have the end-tidal CO2. The care of spinal emergencies, yes, standard precautions, of course we need that. Maintain the patient airway, okay, keeping the spine in the proper position, trying not to adjust or move that neck more than we need to. Mobilization of the spine, again, it's awesome that you guys have actually started working on this. So we've seen some of the things with spinal precautions, right? I don't force that head to get into this position, but if you can naturally align that, that would be great. But stabilize that patient in the position found. Keeping in mind, we will still need to transport them. So again, as best as you can. The supine patient, this is where the backboard comes in. Again, different tools that are out there, such as a vacuum splint or the mattress that are out there. It's, again, just another way to provide that stabilization. Vacuum mattresses, I do believe we have some of these. Don't know how popular they are in the actual field use of this, but there's certainly ways we can put someone onto the spine board in lieu of a vacuum mattress if you don't have that. For seated patients, the KED, the Kendrick extrication device, again, that device that still enables you to have protection of the cervical spine and kind of goes down to the waist. You put those belts on. It's important because I know this is only verbalized in the station. Then you verbalize moving that patient who's on the KED board onto the long spine board. This is just to get them out of the area that they were seated in. Most commonly, that's going to be a vehicle. Standing patients, again, there's SMRs, documenting the heck out of this stuff. Patient was found standing next to the automobile at the scene. Patient denies, neck or back pain. Great. But again, if someone's ambulatory prior to your arrival, means they've been walking around the scene, you should really document that. Spinal mobilization, again, if there's any that index of suspicion, again, this could be a spinal injury. Anyone that has a head injury, we think there could be the spine affected as well, right? We saw it. It's all connected. So this can affect that. Huge part of the chapter. As long as we get those two things down, we're awesome. Manual inline stabilization, the C-collars and the backboards. I like how they say it now, or follow the local protocols, right? Whatever your local protocols are, that's what you're going to, of course, follow. The KED, you've actually seen the KED board. I think you played with the KED board. Awesome. Let me see what the afternoon class is doing right now. Okay. Again, I'm sorry. This is our attempt to make sure we get this stuff to you rapidly. Again, we missed you. We should have had this today, but my apologies. Your helmet removal and how those things are actually coming off is something I know you practice in class. The best way we can remove that helmet is, keep in mind, you can leave the helmet on if there is not an airway issue. If the person's in cardiac arrest, and obviously we need to get that off because it's going to affect our airway and the ability to manage that airway. The two-person job, at least, again, holding the shoulders down and trying to do that, because all helmets that go on should be snug. And if you were just to lift that up, if you've ever worn a helmet, you know that, but it can cause that elongation of the spine, which is why we're so careful in using at least two people with that. A lot of the helmets and the helmet removal now, there are specialized helmets, at a track or trainers, or even at a football game. They have certain ways they can take those things off easier than just trying to bull rush through it, right? It's a slower process because we don't want to elongate that spine. Putting your fingers inside the helmet, again, to help pull it, but obviously I'm going to need two people for that. Awesome. Again, my apologies for the interruption there. I am going to get this loaded for you all, and we will get the other two. I know I owe you two more. We'll definitely get that stuff rolling for you.